lecture in the series of Chemistry Academy webinar. I am honored to invite Dr. Thank you, Nikhil. So I'm honored to invite Dr. Rinchu Loomba, who is Professor Biochemistry at Christian Medical College and Hospital, Ludhiana. She has overall 20 years of experience. Talking about her academic and administrative roles and responsibilities, so she is Faculty Medical Education Unit, member Institutional Animal Ethics Committee, member Mortality and Morbidity Committee, AET COM Coordinator. Talking about her academics, so she is a life member for ACBI, AMBI, ACCLMP, CAHO, MB State Representative for Punjab. Talking about her social responsibility, so she's member of Ludhiana Management Association, IMA Rotary Club, Ludhiana, and Midtown. She has overall 12 international and national publications. She's done extensive work on selenium toxicity in seleniferous belt of Punjab. She has been an external subject expert in selection and promotion committees of various universities like Pandit B.D. Sharma University of Health Sciences, Rohtak, RML Lucknow, and NDRI Karnal. Have delivered talks in various consortiums, academic meets, and conferences. She has been a panelist for various academic panel discussions, has been involved in organizing committee of a number of academic and scientific events, including National Conference of AMBI at CMC Ludhiana in 2013. Her areas of interest are teaching and clinical chemistry and immuno. Her professional strengths being she's trained in a number of biochemical techniques like cellulose acetate, capillary immunofixation, electrophoresis, paper and gel chromatography, immunofluorescence, molecular biology, basic techniques. So we have a versatile speaker today. And without wasting further time, may I request Dr. Rinchu to take over the stage? Thank you.
Good evening, esteemed colleagues. It's a pleasure to welcome you all to this national webinar on post-analytical quality challenges. Today, we are focusing on a critical yet often overlooked aspect of our daily work, enhancing accuracy, efficiency, and communication in laboratory practice. These elements are vital for all laboratory personnel and profoundly impact patient outcomes. Dedicated laboratory professionals, be it MD doctors of laboratory subjects, laboratory managers, quality managers, supervisors, or senior technologists, we all recognize that a meticulously performed test, perfected with analytical precision, is ultimately only as good as its final interpretation and communication to the clinician and ultimately to the patient. We are all at the forefront of diagnostic healthcare, and our commitment to quality is absolutely paramount. So today, our objectives are clear. First, we will revisit some critical aspects and common challenges within the post-analytical phase. Second, we will discuss the common pitfalls we encounter and, more importantly, their direct impact on patient care. Third, we will explore practical strategies and leverage modern technologies, particularly LIS, for enhancing post-analytical quality. And finally, we aim to foster an interactive discussion, learning from each other's experiences and best practices. So the first and the foremost is the criticality of the post-analytical phase that is beyond the bench. Often, when we talk about lab quality, our minds immediately jump to pre-analytical sample collection or analytical instrument calibration. But the journey of quality doesn't end when the instrument finishes its run. The post-analytical phase, the interpretation, validation, reporting, and communication of results is equally, if not more critical. This is truly beyond the bench. The impact on patient care here is profound. An incorrect interpretation, a delayed report, or a communication gap can directly lead to serious consequences. Misdiagnosis, delayed or inappropriate treatment, adverse patient outcomes, and even increased healthcare costs due to unnecessary follow-up tests or prolonged hospital stays. Leading organizations like the World Health Organization and CLSI, Clinical and Laboratory Standards Institute, consistently emphasize the significant contribution of post-analytical errors to overall laboratory errors. It's an area where our vigilance can make a tremendous difference. To start, I have a quick introspective question to ask. How many of us have encountered a situation where a technically perfect result, one that passed all the internal QC, still led to a clinical misstep due to an issue arising in the post-analytical phase? Think about it. And chances are, most of us have. Result interpretation beyond the reference ranges actually is truly an art and a science. It's far more than just flagging values as high or low based on a reference range. The numbers alone tell only part of the story. The clinical context is absolutely key. This means understanding the patient's history, their current lab results. Trend analysis is invaluable for understanding the progression of a condition or response to treatment. And critically, what was the specific clinical question posed by the requesting physician? Remember, we need to provide answers and not just the data. Numerous factors can influence result interpretation, like physiological variations, age, sex, diurnal rhythm, even ethnicity can affect normal ranges. For example, potassium of 6.3 millimoles per liter is a critical high value for a 40-year-old adult, but it's normal for a newborn. Cortisol of 4 micrograms per deciliter is low for a morning sample, but it is normal for an evening sample. Then interfering substances, drugs, the presence of hemolysis, lipemia, or icterus in the sample can significantly alter results. For example, patients on amiodarone, a common cardiac drug, can have high FT4 values with low FT3 and often with normal or transiently elevated TSH, simulating a euthyroid 6 syndrome-like picture. Heparin, when given intravenously or subcutaneously, can give a false picture of FT4 elevation. Then analytical interferences. Issues like heterophile antibodies can lead to a falsely high or low immunoassay results. Hence, once again, the clinical context is the key. Every member of the laboratory personnel plays a vital role in this. From the initial data review by our technologists to the final interpretation and sign-out by our laboratory doctors, every single step is crucial. We are not just reporters of numbers. We are vital contributors to patient diagnosis and treatment pathways. Our insights truly inform clinical decisions. So let's see what are the common errors in post-analytical phase. Let's get practical and talk about these common errors we frequently encounter in the post-analytical phase. Understanding these categories helps us to target our improvement efforts. We can broadly classify them as, so first and foremost, the interpretation errors. This is where we might misunderstand the clinical significance of a result, overlook the critical values, or fail to correlate the lab findings with the patient's overall clinical picture. A slightly elevated AST and ALT values may lead to suggestions of extensive liver workup, overlooking the history of statin intake, which is known to cause mild asymptomatic transaminitis. So if I talk of the examples, the list is endless. I'm going to cite the commonest and probably just one or two in every case, just to emphasize the need to classify these errors and to understand that each of them is important. So next is transcriptional errors. While less common with integrated LIS systems, manual data entry mistakes can still occur in some workflows, especially with external results or legacy systems. Report generation errors. These include incorrect patient demographics on the report, missing essential information like units or methodologies, or even simple formatting issues that make a report hard to read. Okay, let's talk of the interpretation errors. For example, vitamin D value of 13.5 being 5 nanogram per ml, being reported as 31.5 or 135 nanogram per ml can have a profound impact on patient's treatment plan. Now, 31.5 being normal and 135 being hypervitaminosis D can have impact on the treatment plan. We move on to report generation errors. These include incorrect patient demographics on the report, missing essential information like units or methodologies, or even simple formatting issues that make a report hard to read and interpret. And this may invite the clinician referring to his own reference ranges or maybe calling the laboratory personnel to ask for what is the meaning of the value that has been released by the lab. So unnecessary time waste and delay in the diagnosis and treatment plan. Validation errors. Releasing results without proper technical review by a supervisor or without the necessary biochemist or pathologist authorization for complex or critical cases is as significant a risk. For example, following the lab's protocol for validating a critical value could actually for example, a random blood sugar value of 38 milligram per deciliter released as a critically low value by the technologist under pressure without following the lab's protocol for validating a critical value could actually be a false low value to that extent because of collection of blood in a wrong vial. Then we move on to communication errors. This is a major one. Delayed critical value notification, miscommunication with clinicians, or having incorrect contact information for the requesting physician. For example, a sudden rise in troponin I or T value of a cardiac inpatient could indicate myocardial infarction, which should actually be communicated abruptly to the treating team. However, due to technical issues like phone out of order or the new number of the CTU not updated in the directory, etc., leading to result not being conveyed in time can have a bearing on the timely diagnosis, intervention, and patient outcome, in this case of an acute cardiac event. Then archiving or retrieval errors. Difficulty accessing historical patient data or in rare cases, lost reports can severely hinder continuity of care. For example, loss of the archived renal function data due to any reason may incapacitate a nephrologist to accurately trend the patient's kidney function, making it difficult to optimize treatment strategies and predict the disease progression. These situations are very real and highlight the impact of these errors on our daily work and patient safety. A lab report is a final deliverable product, our output to the healthcare team. It's much more than just a printout. It's a crucial document guiding clinical decisions. Therefore, clarity and completeness are paramount in this case. Essential elements that must always be present include patient identification, referring physician's name, the exact test name, the result with correct units, established reference ranges, the methodology used, and critically, the date and time of both sample collection and reporting. Equally important is the inclusion of relevant comments or interpretive notes. These could be caveats about interfering substances, suggestions for further testing, or technical limitations of the assay. Remember, standardization is vital. Consistent report formats across different tests and ensuring all necessary information is present. It helps clinicians quickly extract the information they need without any confusion. We must also be mindful of legal and ethical considerations. Data privacy, adhering to regulations like Health Insurance Portability and Accountability Act or General Data Protection Regulation, the European Union, ensuring the accuracy of the report, making it tamper-proof, and guaranteeing secure transmission. All these things are non-negotiable. Finally, we can't ignore the impact of a software glitches, LIS bugs, errors in report templates, formatting issues, or even simple printer malfunctions can directly compromise the quality and usability of our reports. Regular system checks and user feedback are essential here. I can just remember a time when one of the printers in the printing area of our institute actually was giving an error. It was mispatching the values against the test names. So the value of the lower test would come against the upper one, and the whole report was going haywire. Just imagine what havoc could have been played had it not been identified in time and rectified. Result validation is truly the final gatekeeper before a result reaches the patient's chart. It involves multiple levels of scrutiny. Technical validation, typically performed by experienced technologists or supervisors, is the first critical check. This involves reviewing instrument flags, ensuring QC results were in range, verifying calibration and linearity, performing delta checks against previous patient results for consistency, and assessing the overall plausibility of the results. Does the result make sense given the test requested? Like, for example, in a EDT adulterated sample of serum, if a potassium is coming 35 and is not cross-checked and released, does it even make sense? Is it possible for a live person to have a potassium value of, say, 35 or anything like that? For complex or critical results, lab doctors' review and authorization is often required. Result validation is truly the final gatekeeper before a result reaches the patient's chart. It involves multiple levels of scrutiny. Technical validation, typically performed by experienced technologists or supervisors, is the first critical check. This involves reviewing the instrument flags, ensuring QC results were in range, verifying calibration and linearity, performing delta checks against previous patient results for consistency, and assessing the overall plausibility of the results. Does the result make sense given the test requested? The laboratory doctors carry the ultimate responsibility for the clinical interpretation. They will review for plausibility and consistency with the clinical picture. Compare with previous results, identify critical values, and ensure appropriate action is taken, and add interpretive comments that guide the clinician. Based on initial results, laboratory personnel, often in consultation with lab doctors, may also need to make decisions about reflex testing or add-on testing. This proactive approach ensures a comprehensive diagnostic workup. The importance of standard operating procedures cannot be overstated. Clear documented procedures for all levels of validation are crucial for consistency, minimizing subjectivity and preventing errors. The consequences of inadequate validation are severe. Misleading reports, clinical mismanagement, and ultimately potential harm to our patients. This is where our deep understanding of the assays and clinical implications truly shines. So what are the most important of all? That is the communication errors. We can perform the most accurate test, interpret it perfectly, and generate a flawless report. But if that report doesn't reach the right person in the right way at the right time, it becomes useless. This is the last mile challenge in laboratory diagnostics. Common pitfalls in communication include delayed critical value notification. Time is often of the essence with critical results, and there should always be a documented policy of the laboratory within what time the critical value will be intimated to the concerned team. Ambiguous reporting of critical values. Is it just a notification or has confirmation of receipt been obtained? So this is once again a requirement of paramount importance that there should be a documented procedure of informing the critical value, confirming it, removing any ambiguity in the value that is being reported. Lack of direct consultation. Sometimes a quick phone call or direct discussion can clarify a complex result better than a written report. Misunderstanding of the lab terminology, limitations by clinicians that is there, and vice versa, can be avoided. We speak labbies and they speak clinicalese. We need to bridge that gap. Inability to reach the right clinician, knowing who is on call versus the primary physician, and having accurate contact information is actually vital. So what are the strategies for improvement? Implement a standardized critical value policy with clearly documented communication procedures and escalation pathways. Establish regular communication channels, whether it's phone calls, secure messaging apps integrated with the LIS, or direct consultation. Organize joint educational sessions or CMEs for both lab personnel and clinicians. This fosters mutual understanding and collaboration. And the importance of such academic events cannot be overstated. Crucially, create effective feedback mechanisms where both sides can easily report issues and suggest improvements. We need to know when our communication is failing. And most of the time, we underestimate the value of effective feedback. We bypass it deliberately just for the fear of getting negative feedbacks. The Laboratory Information System, or LIS, is truly our digital ally in the battle against post-analytical errors. It's far more than just a data storage system. It's a powerful tool for quality management when used effectively. Here are some key features that contribute to error reduction. Automated data transfer. This dramatically reduces manual transcription errors from instruments to patient reports. Built-in validation rules. a well-configured LIS can automatically flag implausible results. It can perform delta checks against historical data, highlight the critical values, and even suggest reflex testing protocols. Customizable report templates. This ensures consistency, completeness, and the inclusion of all the necessary disclaimers and interpretive notes on every report. Automated critical value alerts. Real-time notifications via various channels like SMS, email, direct pop-ups within the LIS, ensuring relevant personnel are immediately informed. Then audit trails. Every action taken on a sample or result, from accessioning to final sign out, is tracked, improving accountability and simplifying the troubleshooting. So all these advantages of LIS can make LIS really work wonders in removing or reducing the post-analytical errors. Interfacing with HIS or electronic health records. Seamless data flow to hospital information systems and electronic health records. It minimizes the delays and transcription errors on the clinician's end. Many LIS platforms offer tools to analyze trends, identify common errors, and monitor the turnaround time, enabling proactive intervention. Advanced LIS can even guide interpretation and validation workflows, though human oversight, particularly from the laboratory doctors, remains absolutely essential. However, remember that leveraging the LIS effectively comes with its own challenges. Proper implementation, ongoing maintenance, thorough user training, and overcoming any resistance to change within the team are some of the challenges which need attention. Improving post-analytical excellence isn't just about what happens after the result is generated. It requires a holistic approach, optimizing the entire workflow from order entry to final report delivery. For improved turnaround time, following points can be considered. Pre-analytical optimization, efficient sample collection, rapid transport to the lab, streamlined accessioning, and accurate order entry are foundational. Then we need to have analytical efficiency also. Automation, intelligent batching of samples, robust instrument maintenance, and efficient workflow within the lab itself are really crucial. Automated result release protocols, efficient validation workflows, and streamlined report distribution directly affect the turnaround time of the lab. And last but not the least, clear communication protocols, especially for the critical values, expedited reporting, and clear escalation pathways are really essential. For enhancing the report quality, the regular staff trainings are paramount. Training on interpretation nuances, validation procedures, effective LIS usage, and communication protocols need to be in place. Standard operating procedures ensure that they are comprehensive, clear, regularly updated, and rigorously followed for all post-analytical protocols. It has been quite oftenly seen that the SOPs for the pre-analytical and analytical procedures are very well documented for most of the labs. But usually, the importance of SOPs for the post-analytical processes gets ignored. Then quality assurance programs. Implement robust internal and external audits. Participate in proficiency testing and perform thorough root cause analysis for any identified errors. Actively solicit feedback from clinicians and our internal staff also. This helps identify areas for improvement that we might otherwise miss. Continuous improvement initiatives, methodologies like Lean Six Sigma can help systematically identify and eliminate the bottlenecks and sources of error throughout the entire lab process. Leveraging the technology, maximizing the capabilities of your LIS and actively exploring the new technologies that can enhance efficiency and accuracy can really improve the quality of a report. Remember, quality is not just a journey. Quality is not just a destination, but it's a journey. So, as we conclude, let's reiterate the core message. Post-analytical excellence is absolutely paramount for patient safety, accurate diagnosis, and for delivering quality healthcare. Our role as laboratory personnel is central and it is irreplaceable. Our expertise, vigilance, and unwavering commitment to quality are vital at every single step of the diagnostic process, particularly in this critical final phase, that is the post-analytical phase. And last but not the least, embrace technology. The LIS is a powerful tool indeed, a true game changer. But remember, it requires skilled operators. That's all of us to utilize its full potential. And finally, really important, foster collaboration. Strong, open, and continuous communication between the lab and the clinicians is the cornerstone of effective patient care. We are all part of the same healthcare team working towards the same goal. The journey to laboratory perfection is ongoing. It requires a proactive, collaborative, and continuously learning approach. Now I would like to open the floor for your questions. This is an opportunity for us to engage, share our experiences, and discuss any challenges or successful strategies that you may have implemented in your own laboratories. Let's learn from each other and build on our collective expertise in optimizing post-analytical excellence. Please feel free to ask anything that is on your mind.
Prior to the question and answers, I would take this opportunity on behalf of the entire team Mindray and the fraternity to thank Dr. Rinchu for a very enlightening talk on post-analytical quality challenges. Your in-depth knowledge and practical insights added immense value to the session. It's given us a deeper understanding of often overlooked but critical phase of the laboratory diagnostics. Your talk has brought much needed focus on critical but often under discussed phase of the laboratory process. The clarity with which you have addressed the complexities of post-analytical errors, their impact on patient outcomes, and strategies to improve quality and accountability was truly commendable. We are truly grateful for your time, expertise, and practical knowledge you've shared with us. It was a privilege to have you with us, and your contribution has certainly left a lasting impression on the audience. Looking forward to much more enriching and interactions in the future, madam. Thank you so much. Now we open the forum for question and answers. So we have certain questions which I have noted down, madam. The first question is, what should we do when fasting is higher than postprandial sugar?
The history has to be taken from the patient. There is a term called as fasting hyperglycemia. That has to be kept in mind. So the clinician has to be informed about that. Do not always think that fasting blood sugar cannot be higher than the postprandial. Secondly, if a patient is already a diabetic patient, maybe on treatment, and before giving the postprandial sample, the patient might have taken the regular dosage of his oral hypoglycemic agent, which will lead to a lower postprandial value as compared to the fasting value. So all these things should be taken in mind and not just outrightly think that there is some estimational error.
So the next question is lot variation observed in CA125 results by different laboratories using different instruments. Same issues with torch parameters like HSV. So how to go about that?
But pardon me, I started my webinar with the statement that whenever we talk of the quality, our mind goes to the pre-analytical phase or to the analytical phase with a fully automated analyzer and IQC in place and laboratory report. So once again, I can see the questions being directed to the analytical phase. Nevertheless, I would really love to answer that. So whenever there is a lot variation, standardization, different scene with different methodologies, we should stick to our own one. Definitely, this is not only for the tumor markers. There are a number of parameters where you can see that the values really vary either with the principal or with the analyzer. So there are very less parameters in which the values will not vary from an analyzer to analyzer or from principal to principal. If you look at the ECAS also, that is why they provide us the values for according to the principal and according to the analyzers, because the expectations of the recovery is expected is different for different principles. So I don't think we should get perturbed by that. The only thing is for our own principle in our own range, the values should come within the specified 2ST ranges.
So going to the next question, can you please tell us how we can implement automated critical alerts in a medium-sized hospital laboratory?
It depends upon your choice of the LIS, the software that you choose. Quite a number of softwares actually come with this inbuilt facility where automated critical alerts are generated. There is facility to put up the values, the lower and the higher values in the software itself for all the analytes that can be critical to the life of the patient. So you put those values after making the right choice of the software that you use, and automatically the results will be flagged with the critical alert. So decision for the LIS, the software that you choose according to your lab, will be guided by a number of decisions like your what is your budget for that, what is the capacity of the software. So that you have to customize it according to your lab's capacity.
So moving to the next question, in a corporate hospital, what is the ideal sample collection technique for IPTH sample test? How to transport the sample, add-on time from the collecting sample?
There's nothing so much specific nowadays about collecting the sample for IPTH. That depends upon the principle. Since the half-life of PTH is very less, it is few minutes only. So it depends upon the principle. If it is liable to be, if it gets broken down on exposure to heat and light, so the sample should be actually taken and transported. I'm sorry. The sample should be transported to the lab immediately after collection on ice in cold temperature so that there is no breakdown of the PTH molecule. So again, it is principle dependent. What is the principle of the kit? Whether you need to transport it in cold, maintaining the low temperature, otherwise it will get broken, or it does not affect.
Is the critical value informed before approving the results?
See, we need to have a standard operating procedure for informing the critical alerts. Ideally, critical alerts should never be informed without following that protocol, and that protocol involves validation of the result. So validation of the result will differ from one lab to another, but has some critical definitive steps to it. We need to cross-check the value just to rule out any estimational error. Then we need to ensure that the sample was correct. There was no pre-analytical error that may have affected the value. And then last of all, the very important one, the critical value that is being informed should be actually confirmed with the authorized signatory and not informed like that.
So the next, I think we take some few questions, madam. Some 4-5 questions. Is it okay for you?
Yeah, sure, no problem.
Okay. Opinion on using software in analytical.
Sorry, Kshama, I lost touch with you. Can you please repeat the question?
What is your opinion on using the middleware software in post-analytical reporting?
I'll be very honest, I do not have a personal experience with middleware software because I personally am from a tertiary care hospital. Rather, I would invite opinions of people who have a first-hand experience with these. Anybody who can contribute to this. Otherwise, what I know is that people are definitely using and successfully using these middleware softwares. But personally, I cannot put a light on it. We have 3 participants volunteering to give an answer to that. Shama, can they be given an opportunity?
Ma'am, they can give the answer in the chat box. So you can type, anybody who can answer this question can type the answer in the chat box. Moving to the next, what is the, it's an important question. I just, yeah. Please tell interpretation of TFT because T4 is, T3 is, and TSH also normal. So,
Sorry, once again,
how
there
to
was a
interpret?
network issue. I missed half of your question. Can you please repeat it?
Okay. Please, can you hear me now, ma'am?
And now I can hear you.
I think your network is a bit unstable there.
Yeah, looks like net is slightly unstable. Yeah, tell me please once
So
again.
please tell interpretation of T because in some patients T4 is high, T and TS is normal.
Your voice is breaking. T4 is high, TSH is normal, and T3?
T is normal, T is high, and TSH is normal.
See, first of all, whenever there is a single value which is getting deranged, first of all, we should always take into account the interfering factors. There are drugs which interfere with T4 values, causing an erroneous increase. Like, for example, I mentioned amiodarone. Amiodarone is one common cardiac drug which will cause an elevation in FT4 values without TSH and FP3 being affected. So likewise, there are a number of other drugs. So we need to keep into account the interfering factors. Look at that. There is a long list. So, and then take the history and then interpret accordingly.
Or is it my internet that is stuck?
Yeah, Shama, it is your internet. You can switch off your camera if at all.
Okay.
To save bandwidth.
Shama, if you're talking, you're not audible to me.
Yeah, ma'am. Now. So I switched off. Yeah. So can I take the next question, ma'am?
Yeah, please go ahead.
Agent lot has been changed and QC recovery is lower bias with the lot. Agent QC recovery is near to mean, but patient results are satisfactory. Do we need any activation or escalation?
Shama, if you don't mind, very humbly, can I request all the participants to honor today's topic and direct all their queries to post-analytical phase? I think
Ma'am, most of the questions
are from analytical phase.
pre-analytic.
Can we have some specific
one question
from
very
post-analytical
interesting.
phase?
What should we do when potassium millimoles in OPD patient, no value?
Shama, your net is very unstable. What should we do when potassium value is? I missed the value.
14, 4.
Okay. So now a 14 value of 14 probably according to me is not compatible with the live patient. So immediately what I would think of is there is some mixing in the sample. And the most common mixing that we have seen is of potassium EDTA. Potassium EDTA, like for CBC, if the sample has by mistake got mixed up or the phlebotomist, just to make up the volume, before mixing the EDTA sample, has transferred some volume from the EDTA vial to the serum vial, or maybe the order of the draw was not correct, or maybe the patient was on IV line with potassium chloride infusion going on. So all these factors are the ones which can cause an erroneous increase in the value. Otherwise, a value of 14, okay, this is an OPD patient, cannot be on potassium infusion. But then a probability of potassium EDTA, which is the commonest anticoagulant being used, mixing with that, must be kept in mind. To rule that out, what can be done is we can, in the lab itself, put up calcium. If calcium also comes onto the lower side, and we can also go in for alkaline phosphatase estimation also. So if both of them are on the lower side than we expect them to be, it will substantiate our suspicion of potassium EDTA mixing in the serum. I hope I have answered.
Yes, ma'am. So we can have one last question. Somebody's is can you please mute it?
I can see one question on whether the hemolyzed sample can be used or it should be directly rejected. I'm sorry, Kshama, I've jumped to it because I could see it on my screen. Can I answer that? Am I audible, Kshama? Shama's net seems to be unstable. If I am audible, I'll answer that. I just saw it. Okay, so we don't need to directly outrightly reject a hemolyzed sample. Most of the automated analyzers these days have the facility of giving us the HIL index. So depending upon the extent of hemolysis, yes, the sample can be accepted, but there are certain parameters which shouldn't actually be reported on a hemolyzed sample. The foremost being potassium, because potassium being an intracellular ion, even the slightest of the hemolysis can cause a lot of interference in its true value. It can cause a false positive value. At the same time, calcium and phosphorus, because they have a very significant contribution coming from the intracellular pool, should also be either not reported or if reported with caution and with a disclaimer underneath. Rest, like with my personal experience, urea, creatinine, most of the RFTs, enzymes, they usually do not get affected by the hemolysis if it is a mild hemolysis.
Now, because I lost connection in the middle.
Yeah.
Because it's raining heavily in Mumbai and very difficult for a stable connection. So constraint, we can like later on we can have questions answered. The questions are there.
Sure, Shama.
So yeah, so it was really wonderful talking with you, and you as a expert like addressing our audience. A special thank to our audience also, who has been very active in, because I see a lot of Q&A section as chats. I'm really sorry that we cannot answer. We've taken some of the important questions during at industry. So we just have a 5 to 10 minutes talk from our product manager, senior product manager, Anil Makhija, and we will take you through the chemistry solutions and the high-end solutions that we have, the integration of clinical and CLIA. So this we have used from this year, and we would like you all to just have a look at that instrument of ours. Thank you. Ma'am, you can stay and then, like, we will leave.
Sure, Shama.
It's just a minute introduction to
Absolutely no
instrument.
problem.
Yeah, thank you very much, Shama. And thank you very much, ma'am, for such a wonderful presentations. Now, I am Anil Makhija, Senior Product Manager, Biochemistry. So I'm going to present about the integrated solution from Mindray. So we have integration of chemistry in CLIA. So let me share the screen. Okay. So these are the three types of integrated solutions we have in Mindray. First is M680, that is combination of BS600M and Cl2600I. Now biochemistry is 600 tests per hour, and with IC is 800 tests per hour, and immunoassay is 240 tests per hour. So the space it occupies is 2.2 meters square. So this is suitable for medium lab. And then we have other integrated solution, that is M980. This biochemistry is 1000 tests per hour, with IC is 1200 tests per hour. And again, CLIA part remains the same, 240 tests per hour throughput. Now this occupies 2.6 meters square of the lab space. This is ideally suitable for medium end to high end customers. And then lastly, we have M1000, which is a very high end integrations where the biochemistry is BS2800M, which is having 2000 tests per hour throughput, and CL8000I, which is 500 tests per hour throughput for immunoassay, and it occupies 4.5 meters square. So this is suitable for high-end customers. So the benefit of M series is one tube solutions. So you have a single tube for chemistry and CLIA. So you don't have to split in between two different analyzers. We have very smaller footprints, like 2.2 meters square to 4.5 meters square based upon the workload. We have three different types of integrations. We have an excellent throughput, starting with 800 test throughput till 2400 test throughput for biochemistry, and from 240 tests to 500 test throughput for immunoassay. It can be easily connected and easy to operate, and it can be on-site integration is possible, where if you have only chemistry systems, in the future you can integrate with CLIA, or it could be vice versa. Okay. So in the biochemistry analyzers, we have given a lot of alarming facts. We have first is enzyme linearity extension. That means if the linearity of the enzyme is, let's say, for ALT and AST is 1000, so you can extend up till to 3000 and more. So any critical value samples is not been falsely low reported, so you get a correct results with enzyme linearity extensions. Auto dilution and auto rerun, especially for TG, high value samples go for auto dilution and auto rerun, and you get a correct values. And for antigen-antibody reactions, it's for microalbumin or RF or ASOs. So there is a prozone effect due to antigen excess or antibody excess. So again, this gives you a correct results after dilution and rerun. Okay. High sigma matrix. So this is the most important criteria we see while selecting a biochemistry analyzer. Like, what is a sigma matrix for biochemistry parameters? So in this, we have more than 75% of the parameters which are routinely used are 6 sigma, and more than 95% of the routine biochemistry parameter, it is between 5 sigma to 6 sigma. So this denotes that world-class and excellent qualities. So here, your bias is reduced, your CV is reduced, so you get a good EQA score, you get good PT scores, and you get a very less CV with our biochemistry parameters. Okay. So this is about Cl2600I, reliable yet accessible. That is a chemiluminescence immunoassay. So this can throughput of less than 1 meter square, throughput of 240 tests per hour. It can be integrated with biochemistry. Okay. So it's very compact. Footprint is less than 1 meter square. Integrated with chemistry analyzers. It's a worry-free. We have FS sampling technology. Then we have enhanced washing systems that give you carryover less than 0.1 parts per million. It's very user-friendly because of it's free from daily maintenance and it has low hidden cost. So to summarize the Cl2600I benefits, 240 tests per hour, it has 25 positions for the reagents, 70 positions for the samples. It's daily maintenance free and bulk cuvette loading. So when it is combined with chemistry, it becomes M680. Combined with PS1000M, it becomes M980. So thank you very much. This is an end of presentation of integrated solution from Mindray. Thank you.
Thank you, Anil. And so we are well in time. We have not wasted a single minute. And like in the chat box, I just wrote, if there are any topics of your choice, you can let us know so that we can, in the upcoming webinar in September, we can take up that topic. So thank you, everyone. Thank you, Dr. Rinchu. Thank you very much. And all the participants. Thank you very much.
Thank you, Kshama. Thank you so much for giving me this opportunity. And thank
Ma'am,
you all
it's
the
always our
participants.
pleasure.
It was wonderful all the time interacting with you. But from the time we decided on having this webinar till date,
Yeah.
you have followed through. It was total pleasure. And it's been a privilege to share all the insights with such a dedicated group of laboratory professionals. Once again, a heartfelt thank you to all of you.
Thank you.
Thank you, Dr.
Thank you,
Rinchu.
everyone.
Thank you.
Thank you.
Thank you all. Please do give us a review in the link that we have shared in the chat box. Thank you very much.